Well, hello, everyone. Welcome to Treating Panic and Agoraphobia, a Cognitive Behavioral Approach. My name is Dr. Aldo Pucci, and I'll be presenting our webinar today. We thank you for signing up for this webinar today. Very thankful for that. We're going to have 100 people today online with us learning about panic and agoraphobia. Now, a couple of housekeeping issues. First of all, about 5 minutes after the conclusion of the webinar, you will receive an email with instructions on how to obtain continuing education credits. If you do not receive that email 5 minutes after the conclusion, then be sure to check your spam or junk folder because it likely will be there. And if you do not receive it, get a hold of us. We'll be sure to send it to you. Also, while we have, this is only a 2-hour training today, and we have 100 people, I'll do my best to answer any questions that you have along the way. And the best way to ask a question is on the right-hand side of your screen, or some of you, if you're using a mobile device, it might be on the bottom. There's a place where you can enter a statement or a question in the chat section. So if you would like to ask a question, be sure to enter that there, okay? We have folks from all over the country attending today and various parts of the world as well. So let's go ahead and get started this morning. Treating, or today, some of you, it's afternoon, treating panic and agoraphobia, a cognitive behavioral approach. Now, I had the great fortune of being trained originally in cognitive behavioral therapy by one of CBT's pioneers, Dr. Maxie Maltzby Jr., who developed rational behavior therapy. Now, Maxie was a student of Albert Ellis's, the grandfather of the cognitive behavioral therapies in the 1960s, and then he went on to develop his own approach that he called rational behavior therapy. And Maxie and I were very involved with each other. He was very involved with our organization until he passed on in 2016. Having had the very fortunate, I was so fortunate to have received training from him and been so involved with him, I realized at one point I had the same experience with Maxie as he had with Al, that it was no longer fair to call what I was doing rational behavior therapy any longer, because it wasn't. I'd been influenced by other approaches to CBT, as well as developed some of my own techniques and theoretical aspects. So what I'd like to share with you today is a very systematic way of helping people to overcome their panic and their fear of leaving the home. Now, while these are three pretty decent therapists, if I may say so myself, three far better therapists are Dr. Howard, Dr. Fine, and Dr. Howard. Beat the pants off the previous three anytime. And if there's ever a time when I show this picture and people do not know who they are, that's when I'm officially retiring. The world has come to an end. Okay. Now, I hope that you all received the link for your manual. You were supposed to have received it yesterday. If you did not, be sure to let me know and we'll send you a link to it. But one of the things, just about every training that I conduct, one of the things that I make sure that I emphasize is that contrary to what many people think, there is no such thing as cognitive behavioral therapy per se. You would not believe how many very well-trained therapists do not know this, that there is no such thing as cognitive behavioral therapy as a distinct psychotherapeutic technique, just as there is no such thing as medicine. There are various medicines, but if someone said, if a doctor said, I'm going to give you some medicine, you would have no idea what drug they were going to give you, right? The term cognitive behavioral therapy is a very general term for a classification of therapies with some similarities. Under this umbrella, so to speak, of cognitive behavioral therapy, we have various approaches. There is the original approach, Albert Ellis's rational emotive behavior therapy. There is Aaron Beck's cognitive therapy. There is Maxie Maltzby's rational behavior therapy. There's the approach that I like to take that I call rational living therapy. There's also Jeff Young's schema therapy that you might be familiar with. Okay, so these are all approaches to cognitive behavioral therapy, but there is no distinct psychotherapeutic technique called cognitive behavioral therapy. That is a classification of therapies with some similarities. Okay, all right. Now, in terms of our objectives for today, what are we hoping to achieve in these 2 hours that we're going to spend together? First, we're going to demystify panic and agoraphobia to remove the perception that it just happens. That is a very common experience and something that we very often hear from people who are panicking, is that it just comes out of nowhere. It just happens, and I don't know what to do about it because it seems as though I have no control over it. So we're going to demystify that entire thing, that entire experience. Secondly, we're going to discuss how to teach our clients to identify reflexive thoughts when it appears as though no thinking occurred. So we're going to help them to break down the reactions into the ABCs of emotions. But sometimes it will seem to them as though no thinking occurred. And when that's the case, we're going to show them how to identify what they were actually thinking. We're going to discuss symptom stress and why it is absolutely essential with people who are panicking, why we address this, and how to remove it. But unfortunately, what I have found in my experience over the past almost 35 years now is that very rarely is symptom stress addressed. And it's so unfortunate. It very much plays a role in so many of the problems that people present us with. We're going to discuss how to help our clients dispute and correct panic-producing thoughts. So it's not enough just to identify those thoughts. We need to know how to help them to dispute them. And then the final objective, how to help the client produce and practice new rational replacement thoughts. So we're not only going to show them how not to think, we're going to help them to learn how to produce a new replacement thought and how to practice that thought so it's there for them when they need them, so that they stop panicking and they feel comfortable leaving their home. Okay? All right. Now, if you would please turn, if you have your manual, please turn to page 3 in your manual. And we are going to discuss just what is anxiety and panic. Here, I'm going to, there we go. Just what is anxiety and panic. And as I said, if you have any questions, you can ask them in the chat section, and I'll do my best to respond to them. First of all, anxiety is the emotional, behavioral, physical result of fear. Okay, so you are afraid of something, and therefore your body responds accordingly. But notice the second point, fear is thinking. So what happens when a person feels anxious is they first perceive a threat, and then because they perceive that threat, their brain then tells the rest of their body to respond accordingly. So therefore, the brain signals to the adrenal glands to start pumping adrenaline. And as a result, the heart will start to beat faster and harder. Your respiration changes. Blood flows from the extremities into the more major muscles to prepare for action. And you might become jittery, and blood pressure increases. This is all the natural, normal, physiological response to perceived threat. Okay. Now, what is panic? Panic is the extension of that. Is intense anxiety. So, with panic, a person is perceiving a severe threat, and as we'll talk about later, they likely are equating something with a life or death situation, and as a result, their body responds accordingly, as if they were in the woods they turned around and a bear were ready to attack them. It's the same response. Okay? And then notice the fourth point. If anxiety and panic-like symptoms are the result of a physiological problem, then it's not anxiety. Unfortunately, our field tends to lump them all into the same category, so that if a person's anxiety-like symptoms or panic-like symptoms are the result of an adrenal tumor, then they will call that anxiety. Whereas the way we look at it, that's not anxiety. That's a problem with your adrenal glands. Okay, but anxiety is the result of perceived threat. And so with panic, it's just it's a matter of degree rather than kind. You're very afraid, and because you're very afraid, your body responds accordingly. Okay, and it was designed to do that, and it's supposed to do that. Okay, all right. Any question about that so far before we move on to the next? Okay, so now, excuse me. If you would please turn to page 4 in your manual, and we're going to begin talking about the systematic approach to of rational living therapy to helping people to overcome panic and their agoraphobia. Okay. All right. Now, first, the first step in the rational living therapy approach is to provide the initial assessment, okay, which usually lasts one session, but sometimes more than one, depending on the amount of information that's required of you to gather, depending on where you work, your treatment setting. But typically it's one session. Okay, so now when people approach us, seek therapy because they are panicking, and sometimes as a result of that, they're afraid to leave their home, what they will typically say is, I have panic attacks. Okay. And that's how they'll describe it. I have them. I have these panic attacks. They seem to come out of nowhere. And you know, it's so unpleasant for me. I can't take it any longer, and I need some relief. And as a result of this, what they will often also say is, I'm afraid to leave my home. And as a matter of fact, for many, it's a miracle that they made it to your office to begin with, because they're that afraid of leaving their home. But it's likely that if they do arrive at your treatment facility, it's because someone brought them to you. Someone went along with them, which is a very common experience that they have, and that we see, is that they will be more willing to leave their home if someone accompanies them, but so that they're there for them if they panic. And we're going to talk about that. So what are some questions to ask? First of all, when did you start panicking? Notice I did not say, when did you start having panic attacks? That's something that we're going to work at removing from the way we describe panic. But when did you start panicking? Was anything going on in your life at the time when you started to panic? And then a very logical question that if they have the answer to will help us out tremendously. And that is, what are you panicking about? Do you have any idea why you are panicking? What you are afraid of? And also, is there any pattern to this? Have you noticed? Because very often they will say they, referring to the panic attacks, will just come out of nowhere. You know, it doesn't seem to matter where I am, what I'm doing, what's going on. All of a sudden, it will hit me, they will say. So So we want to determine, is there a pattern? Does it seem as though you're more likely to panic in some situations than others, or in some location rather than others, or certain times of the day more than others? Okay. And very often at first they will say, no, it doesn't seem to, I don't see any pattern whatsoever. And if that's the case, then we're going to give them an exercise to complete that will help us out. Very often they will say, I've noticed that when I tend to panic in the evening after a long day of work, when I sit down in front of the TV and just kind of watch it, that's when I will panic. And they will have no explanation for it. Well, we're going to have an explanation for them, and we'll talk about that later. Okay. But one of the main goals of this first session is to at least begin making the determination: is this panic learned or not learned? Is what they're experiencing a learned problem or a not learned problem? And to determine that, we're going to look at a couple of factors. And by the way, many in our field like to call this endogenous as opposed to exogenous. But I have a real problem with the term exogenous because it gives the impression that something outside of us is causing our emotions and behaviors. We believe it's all endogenous. The question is the person's panic the result of a pituitary tumor or an adrenal problem or a thyroid problem, or is it the result of learned thinking, learned behavior? Okay, so there are several questions that we can ask, several considerations, but the two most important are, first of all, is the emotion or behavior in question a reaction to something? Is the person describing some life circumstance, either past, present, or future, that they are reacting to, that they are dealing with, that they are struggling with? Okay. If it is a reaction to something, then it's very unlikely that that emotion or behavior in question is a result of a physiological problem primarily. It's much more likely that it is learned. Okay. And then secondly, does the person demonstrate any voluntary control over the onset, duration, or intensity of the emotion or behavior in question? Okay. And a very simple indication of voluntary control is if I put my mind on something else, I feel differently. Or if I avoid that certain situation or avoid thinking about this, then I feel differently. That's demonstrating some voluntary control. So certainly if they tell you, well, every time I think about this situation, every time I think of dying from the coronavirus, then I panic. Then that is certainly a sign of a learned panic as opposed to a physiological problem causing panic-like symptoms. Okay. Now, the problem with panic is that often they will sincerely have the impression that indeed they're not reacting to anything, because it certainly seems that way to them. And so therefore, we're going to need to help them to break it down, okay, to see if indeed there is a pattern. And most often, we will identify a pattern once they give us the information and observe that it's learned. But if we see no pattern whatsoever, then there very well could be a physiological cause for their panic. And by the way, some physical problems, some medical issues that can cause panic-like symptoms include mitral valve prolapse, a problem with the heart, premature atrial contractions, or PACs, premature ventral contractions, or PVCs, which are an arrhythmia of the heart. They're usually benign, but they will still produce a fluttering. And then you can have a situation where a person feels a flutter, which is a physiological problem, but then think that they are having a heart attack or something seriously wrong with their heart. And then they have a learned response to that. And that is, oh my Lord, I'm going to die. And that would be a terrible thing, would ruin my day. and then they will panic over that. So in that sense, in that case, there are two problems. One, a physiological, but then a psychological response to that. Hyperthyroidism certainly can cause panic-like symptoms. Adrenal dysfunction, adrenal tumors can cause panic-like symptoms. So there is no doubt that when people come to us for a panic problem, it's not a bad idea at all, even if it seems like it's completely learned, to have them be medically evaluated to make certain that there's not something going on that we're missing. Okay. Now, on top of that, some drugs can cause panic problems, like cocaine, without a doubt, LSD. Most people know that caffeine, too much caffeine, can cause a panic-like reaction. Decongestants can. Too much nicotine can. And then prescribed medications as well, such as asthma medications, Parkinson's medications for Parkinson's disease, thyroid medications, particularly if a person's receiving too much of it for their body, corticosteroids, like prednisone, for example, can cause panic-like problems, can drive your blood pressure through the roof. It happened to me last year. I had to actually be hospitalized for it because doctor prescribed it for my sinuses, and my blood pressure was through the roof. And also medications for ADHD as well. So certainly, if it appears that there is no pattern to this whatsoever, we can't identify a pattern, then certainly we need to look for medical problems that might be causing this. Also, on page 23 in your manual, if you have it, page 23, there is an example of a functional analysis of behavior. So a person comes to us and they say, I panic, and it seems as though there's no pattern whatsoever. It just comes out of the blue, just kind of hits me. It doesn't seem to matter where I am, what's going on, what time of the day. We will ask them. Now, by the way, every time I ask someone to complete a form like this, I ask them to complete it in this manner. I say, if you panic, please document it in this way. If we said, whenever you panic, what we would be suggesting to them is that they will panic, that it's inevitable. That's the last thing I want to suggest. So instead, we will say, if you panic, which suggests indirectly you might not. It's an actual possibility. So if you panic, first of all, write down the date and time. Write down the location. Where were you? Write down what you were doing at the time. And if you can, write down what was on your mind at the time. What were you thinking about at that moment? And then write down what happened after you panicked. Okay? So if you panic, please document it in this way. Break it down in this manner. And then we'll take a look at it. Please bring it in the next time, and we'll take a look at it to see if there might be any pattern that we can identify in terms of what you might be reacting to. Okay, and usually, if they complete it, if they did panic several times, we will notice a pattern. For example, some patterns include they tend to panic when they are at rest. And that's because it's the first time in their day that they've allowed themselves to think about what they're upset about, what they're afraid of. Or sometimes we'll notice patterns related to the presence of other people. And then when we break that down, we discover that, well, actually, they're scared to death of the opinions of others, and being negatively evaluated. Okay, so but this functional analysis of behavior is very, very helpful if they complete it properly. Okay, any question about the functional analysis of behavior? And remember, if you want to ask a question, you can type it in the chat section. Okay. As a matter of fact, if you wouldn't mind, because I haven't had any questions yet, make sure that you're on. If you would like to just say where you're watching us from, just type that in. I'd appreciate that. Help me know that you're on, because there's no way for me to know otherwise until after the fact. So if you'd like to do that, please do that. Okay. All right. Now, one other thing that is so very important when at the end of the first session with the client, and that is to help them to understand about cognitive emotive dissonance. Now, those of you who've had trainings with me in the past aren't surprised, I'm sure, that I bring this up. Cognitive emotive dissonance is the strange, funny feeling a person feels anytime they do something, think something, or feel something that is contrary to what they're accustomed to doing, thinking, or feeling. It feels strange, and that strange, funny feeling gives us the impression that there is something wrong with it. Cognitive emotive dissonance is unavoidable. We will experience it anytime we do something, think something, or feel something that is contrary to what we're accustomed to doing, thinking, or feeling. And the reason why this is so important for the client to understand this, and why it's so important for us to explain this at the end of the first session, is because if we do not, as the client is learning about how our emotions work, with the ABCs of emotions, for example, as they are even imagining themselves going through a day without panicking, feeling calm and comfortable, that will feel strange to them. It will feel wrong to them. And what a lot of people do in response to that is think with their gut rather than their head. And they will come to the conclusion, because it feels wrong, it must be wrong, and they will reject it. Okay, we see it time and time again. That's why it's so very important to help them to understand that that's natural and normal. It's to be expected. Of course, it's going to feel strange to think in a way that's the opposite of what you're accustomed to thinking. Of course, if you're in the habit, if you've been in the habit of panicking, then and of being at home out of fear, then of course it's going to feel strange to leave your home, to even imagine leaving your home comfortably. Okay, of course that's going to feel strange, but that's okay. All that it means is that you're not accustomed to it. Okay, and the more you practice it, and we're going to show you how to practice, the sooner that this cognitive emotive dissonance, this strange feeling, will dissipate, and it will feel comfortable to you. But the only thing that will get rid of this is practice. So it's very important. As a matter of fact, often the reason why there is not a second session is because it felt so strange to be with a therapist the first session, okay, in a therapy setting. And so very, very important to teach them about cognitive emotive dissonance. One other thing is it can be helpful to teach them about progressive relaxation, okay, at the end of the first session. Now, our association has a progressive relaxation program that we've sold for years. But what I decided to do, it's not on there yet, but I am going to actually post that as a free download on our website. Okay, so if you could check on our website at nacbt.org. Matter of fact, I'll type this over here. At nacbt.org, probably sometime tomorrow, there will be a link to where you can download the audio for the progressive relaxation program. And you can actually have your clients listen to it and get in the habit of relaxing themselves this way. Now, why? Because we're going to use that for techniques that we are going to utilize with the client. So this by itself will not do much to help them to stop panicking, because as long as they're equating something with a life or death situation, it's not going to make much difference. But we're going to pair relaxation with imagery of things that they are afraid of. And so if we can help them to get in the habit of relaxing, then that will be helpful. Okay. All right. Any questions so far? Okay, let me check on something here. Okay, so now, let's see here. Okay, so now let's move on to the next step in the therapy. Let me see something here. Okay, please do me a favor, and if you would please, if you could let me know that you're online here with us, I'd appreciate that. Thank you. Okay, we have some folks online here. Some folks were told that, yeah, if you would please let me know that you're online, because I'm getting that some folks are being told that they would not let you get in initially. Okay, I don't know why that would be. Let's see here. Was able to get on after 30 minutes of trying. Oh my. There is, you will be able to receive you will receive an email afterwards that will provide the ability to watch the replay. I'm going to have to get a hold of the folks, the Webinar Ninja folks, to see why that was. You're just granted access. My Lord. Okay. Now, so let's move on, and then we'll see how to deal with that later. Okay. On page 4 in your manual, if you received the manual yesterday, a link to the manual. If you didn't receive it, let me know, and we'll be sure to send it to you. The ABCs of emotions is the second session typically. Now, if we decide during the first session that the rational hypnotherapy technique would be something to utilize at this point, then we will. Now, the main reason we would utilize a rational hypnotherapy technique, and we have trainings through our association concerning the rational hypnotherapy, and their self-study programs as well, is if it appears that the person has extreme difficulty getting to your office for their appointments, and you're thinking, I have to do something to jumpstart this therapy to help them to be more likely to get to us, then we would utilize the rational hypnotherapy at that point. But 9 times out of 10, we will teach them the emotional ABCs. Now, I encourage you, because this is only a 2-hour training, I encourage you to visit nacbt.org. Okay, And I'll type that here once again so that everybody sees. nacbt.org. There is a video section. And on this video section, in this video section, you'll see a 10-minute video of me teaching the emotional ABCs. Okay, so we're going to very briefly go through these to show what we would, to demonstrate what we would show the client. Okay, all right, now, so we'll teach the client that whenever we feel a feeling, three things happen. First, we are aware of something. Then we think or believe something about this thing that we're aware of. And the way we think will be one of three different ways. This will either be a positive thought, a neutral thought, or a negative thought. Now, a positive thought would be something like this is a good thing. A negative thought would be this is a bad thing. And a neutral thought would be something like this isn't a good thing or a bad thing. It doesn't much matter to me. Then we teach the client the way we think about what we're aware of, then tells our brain how to make the rest of our body feel. And that is to see the emotional consequence. And it also tells our brain how to make our body act, that is our behavior. So therefore, a positive thought about this thing that we're aware of tells our brain to make our body feel a positive feeling. We're happy, we're excited. Negative thought tells our brain to make our body feel a negative feeling, depressed, angry, anxious, but negative only means that it's an unpleasant feeling, okay? Not that there's anything at all wrong with feeling that way. And a neutral thought tells our brain to make our body feel a neutral feeling or calm, okay? So the main idea, and like I said, please visit nacbt.org for a greater description of this. The main idea here is that our thoughts cause our feelings and behaviors, not people and things and situations. So therefore, whenever they are panicking, if we've determined, as we talked about earlier, if we've determined that indeed their panic is learned rather than not learned, then we're going to help them to understand that their panic is the result of, thank God, of their thinking. And so therefore, it's a matter of determining, identifying what they're thinking, and then helping them to think differently so as to not panic. And you have an example of this to show the client. It's on page, let's see what page in your manual here. It's on page 11, I believe it is. Yes, 11. There's an example that you can share with the clients. You have the manual you can download and print out for them. And here's one handout to show them this, how indeed it is that our thoughts cause our feelings and behaviors. And then we also teach them that there are three emotional options, not two, very briefly. So that most people believe we're either happy or we're miserable. So they think, well, if I'm not going to react with panic to something, then am I supposed to react happily to something? No. There's this third option, this in between or calm, so that you're not happy about it, but you're not miserable either. Now, we teach folks that feelings that are more along the lines of calm are like sad as opposed to depressed, irritated as opposed to angry. So the more along the lines of calm we feel, the better we feel, number one. And then usually the better we're able to handle the person in a desirable situation, okay? Like I said, this is all summarized in the 10-minute video on nacbt.org. So I encourage you to check that out, okay? All right, now, so what we do then is we ask them to complete a form, part of their homework, after we teach them the emotional ABCs. And this form is on page 13 in your manual. So from now until the next time we get together, if you upset yourself in any way, or if you panic, please break it down to the ABCs. A, this is what I was aware of. B, this is what I thought about it. C, this is how I felt and what I did as a result of what I thought. Okay. Now, when they return for the next session, what we will sometimes hear from clients with various problems, but what we are especially likely to hear from folks who are panicking is this. Well, I knew what I was aware of, that my boss told me that I'm fired. I knew to write that down in the A column. And I knew what to write down in the C column, how I felt. I panicked. But it happens so quickly, I don't know what I thought. I didn't know what to write down in the B column. And it will give the client the impression that no thinking occurred. And it will also give them the impression that A caused C. All I know is he told me that I was fired, and instantly I panicked. However, what we teach folks is that everything we do is preceded by a thought. Everything. So therefore, we know thinking had to have occurred. And what we call this thought in rational living therapy is a reflexive thought. Okay? A reflexive thought is a very well learned, very practiced thought. So practiced, so well learned that is now stored in the brain, ready for action. So that the second the brain is reminded of this thought, it's triggered and off you go. Okay. Reflexive thoughts are very helpful when they're well learned. Rational thoughts that sometimes save our lives, protect us from harm. For example, a reflexive thought is what enables you to slam on your brakes to avoid hitting the car in front of you. Okay. So they're very helpful when they're well learned rational thoughts. They are not so helpful when they are well learned irrational thoughts that produce instant unwanted emotions and behaviors. Okay, so therefore, since a thought had to have occurred to produce that panic, the question is, how do we identify this reflexive thought? How does the client identify this so that then they can be in a position to examine it and dispute it? There is an outstanding question to teach them, and that is this. What does my behavior suggest that I'm thinking? Okay. What does my behavior suggest that I am thinking? Now, the reason this question is relevant and useful is because the human body, when working properly, will always produce the logical reaction to what is thought in the brain. The body is a reflection of what is thought in the brain. Okay? So therefore, we know that the thought, your behavior suggests a logical thought for the reaction. Okay. You hear people say sometimes, well, gee, that reaction wasn't logical. Sure, it was for how they thought. Okay, so when the brain and body are working properly, the body will produce the logical reaction for what is thought in the brain. Okay. Now, so with that in mind, what does my behavior suggest that I'm thinking? A, what is he aware of? My boss told me that I'm fired. C, he panics. What does that panic suggest that he's thinking about what he was told? That I need my job, that without it, I'm going to die. Okay. That would produce panic. So the more that our clients understand about the different kinds of thoughts that produce the different feelings and behaviors, the easier it will be for them to answer that question. What does my behavior suggest that I'm thinking? Okay, so this is so very important when working with people who are panicking, to help them to understand about reflexive thoughts. And that will dispel the myth that it just happened. And by the way, this I know that some of you had difficulty entering the webinar when it first started. And I have no idea why. We're going to have to check with the webinar Ninja people, who the service that we're using, but it is recorded and you'll be able to watch this. Matter of fact, you'll receive an email about 5 minutes at the conclusion to be able to go back and watch this. And please let me know if you have any trouble with that. We're definitely going to have to get a hold of Webinar Ninja and see why we started promptly on the hour. Okay, so one of the most important things we can do with folks is to help them understand that it doesn't just happen. It cannot just happen. There has to be a thought that produces the panic. And with that question, what does my behavior suggest that I'm thinking? We're helping them to identify that. Okay? All right. Now another thing to consider in identifying why the person is panicking as it relates to the ABCs of emotions is to utilize the downward arrow technique. Very often, the client has no idea why they're panicking. And so how are we to know? Well, not only with that question, what does my behavior suggest that I'm thinking, but the downward arrow technique can be very, very helpful. Now, downward arrow technique is used for the B column of the ABCs, okay? So, for example, let's say the person says, A, what was I aware of? I was walking through the mall and I saw an attractive woman. This is actually a client of mine years ago who told me this. At C, how did I feel? I panicked. And what did I do? Because I felt dizzy from panicking, I sat down. And so what was my thought? She didn't even look at me. And that's a terrible thing. Okay. Now, very often they'll leave it just at that. As a matter of fact, very often they'll omit the, and that's terrible. We'll have to help them to finish their thought. Because if he didn't want her to look at him, then he would have been happy, right? So she didn't even look at me, and that's a terrible thing. Now we will utilize the downward arrow technique. And we would ask a question like this. And as far as you are concerned, why is it a terrible thing that she didn't even look at you? And he might say, she must think I'm ugly, and that's a terrible thing. Okay, then I would likely continue utilizing the downward arrow technique. And whenever I do, I ask the client to bear with me because I'm asking a lot of questions. And as far as you are concerned, why would it be a terrible thing if in fact she did think you were ugly? If she thinks that I'm ugly, I must be ugly. And that's a terrible thing. Okay, and if in fact that's a terrible thing, why would it be a terrible thing? Well, because if she thinks I'm ugly and therefore I must be, I'll be alone the rest of my life, and that would be unbearable. Okay. So now we have, and that's what we do with the downward arrow technique is we will continue to apply it until we see an underlying assumption that matches the reaction, that matches the behavior. Okay, so if we see panic, we know that the person is equating something with a life or death situation. And so that's what we're doing with the downward arrow technique is fishing for it until we hear that underlying assumption that matches that panic. And when he says, and that would be unbearable as if it would kill him, then we know that we've found the underlying assumption that we're looking for. Okay. Then once we've taught the client the three rational questions, which we'll talk about in a moment, we will help them to apply the three rational questions to each thought, to the thought and the underlying assumptions along the way. Is it a fact that do we know for a fact that the reason she didn't look at you was because she thinks you're ugly? Do we know that for a fact? Or is that jumping to conclusions? Secondly, if indeed she does think you're ugly, does that mean you must be objectively ugly? Well, actually, there's no such thing as objective ugliness. But what he's really meaning is every woman will view him as ugly because she thinks he is, if in fact she did. And is that the case? And then if no woman on the planet ever wanted to date him, ever wanted to marry him or what have you, would that be an unbearable thing or would that be an unpleasant thing? Something that he would very much dislike, but certainly would be bearable, you see? Wouldn't be the end of him by any means. So then after we've done that, after we've disputed the thoughts, then we would help him to develop a new rational replacement thought, which we'll talk about later, for him to practice so that in the future, when he's in similar situations, his reaction is much different. But this downward arrow technique helps us to clearly understand why he panicked, helps him to clearly understand why he panicked. Okay? All right, so any question about this downward arrow technique before we move on to the next topic? Yes, you will be receiving. I saw you will be receiving an email. It provides that automatically as to how you can watch the entire thing. I have no idea why it delayed in granting access to people along the way. That's we've had some other webinars that's never happened, so we're going to check that out as well. Okay, but you will be able to watch the recording of this, and then get the CEs as well, if that's what you were hoping for. Okay. All right. So let's move on to the next subject then. Now, you're certainly welcome, and I sure apologize. I have no idea what happened with that, but we're going to get a hold of the webinar ninja people. Now, a couple of things to consider, and I believe this is in the back of your manual here. Let's see. You have some shots of the screens here for it. No, it's not. Okay. First of all, we are not treating panic disorder or agoraphobia. So the title of the training is one that mental health professionals would relate to, but it's misleading. And the reason I say that is because we're not treating panic disorder or agoraphobia. Why? Because what we're teaching the client is that they do not have panic disorder. In other words, there is not this thing that dwells within them called panic disorder that makes them panic. And that's one of the main problems with people who are panicking is they believe that because they've been told by a mental health professional, by their doctor, oh, you have panic disorder. So they figure that something called panic disorder dwells within them and makes them panic. However, after we teach them the ABCs and the rational questions, we're going to help them to understand that, thank God, that's not the case. What you are doing is unintentionally making yourself panic because you are thinking panic-producing thoughts that you do not mean to think. You're not intending to think them, but you are, and you're doing so very quickly. And that's why it seems like it just happens. It just comes over you. You have this panic attack. So the first thing we need to do is remove this mentality that they suffer from or have panic disorder. Secondly, people do not have agoraphobia. They believe that being away from home is a dangerous thing. Now, and typically now, obviously nowadays with all this COVID-19 situation, people are afraid to leave home for fear of contracting the coronavirus. But under normal circumstances, their main fear is being away from home and panicking. And we're going to talk about that and what that would result in. So that's why they're afraid to leave the home. So we're teaching people how to refuse to panic and how to feel comfortable leaving their home. That is so important to remove that it monster, this notion that they suffer from this thing that makes them feel this way. Because if they did maintain that notion, that way of describing their experience, and they somehow felt relief in some way, what will always be in the back of their mind is, when is it coming back? Okay. When will it return? So what we're doing is removing the it and helping them to understand that, no, you do not have panic disorder. You're unintentionally making yourself panic. Okay. So very important. All right. Any question about that? Okay, someone has a question. Please type your question if you like. Would you say that? What? Oh, yeah. Well, it's very important because otherwise they will, number one, oh, yes. Yeah, absolutely. I would directly say that to the client. But I would in the replay and also on our website, nacbt.org. But absolutely, I would say that. There is not all that panic disorder is Yeah, right. Well, all the panic disorder is a list of symptoms that mental health professionals have attached a label to. And now all of a sudden it becomes an entity in and of itself that a person has that they suffer from. Now, do you suffer from a COVID-19 infection? Yes. In that case, there is something that's in you that's making you have these symptoms. But you do not have panic disorder. You do panic disorder. Okay. Now, what some of you might have missed is that we make this distinction between what is a learned problem and a not learned problem. So if a person's panic is the result of an adrenal tumor, then we would not call that panic. We would call that a problem with the adrenal gland. Okay? So we're separating learned from not learned. So if you didn't get a chance to see that because it didn't allow you in until later, please check that out on the replay. Okay? All right, now. Oh, yeah, no doubt about it, yes. Okay, so what we're teaching them is that what they're experiencing is what we call unintentional self-imposed misery. So are they panicking themselves if it's a learned response? Absolutely. Do they mean to panic themselves? Certainly not. But they are believing the fearful thoughts that produce the anxiety. Otherwise, they wouldn't feel anxious. So it's a sincere idea that I am in extreme danger, or I'm equating something with a life or death situation, and that's why I'm panicking. But it's a sincere, unless you actually are in a life or death situation, you are sincerely mistaken. You are mistakenly equating a non-life threatening situation with one that is. Okay. And so we were given brains that allow us to perceive a life or death situation and then the body to respond accordingly. But we can also use that same equipment to equate anything with a life or death situation. And if you've been in this field for any length of time, you know that people will equate anything with a life or death situation. Standing in front of a group of people to give a speech, or a girlfriend breaking up with you, a boyfriend breaking up, or not having money to pay the bills. They will equate. They can and do equate anything with a life or death situation. Okay, so that's what we have to determine. Are you indeed in a life or death situation? If you are, then you'd better respond accordingly. But if you're not, then it's time to adjust your thinking, and we're going to show you how to do that so as to feel the way you want to feel. Okay? All right, so then on page 15 in your manual, the next step in the therapy is to teach them the 3 rational questions. And briefly, I'll go over this with you. And there's another video on our website as well that will go into more detail. Is my thinking based on fact? So now that we've given them the homework of breaking down their emotional responses in the ABCs. And so they return the next session, and we're going to review any ABCs that they wrote out for us. Then, and this is typically the 3rd session, we will teach them the 3 rational questions. The first being, is my thinking based on fact? Is what I'm thinking the way things really are? Okay. Now, this is the most difficult for people to respond to accurately because they think they're right. When they're panicking, they believe they're correct in their thinking to produce that panic. Otherwise, they wouldn't bother thinking that way. They would correct their thinking and move on. So that's why it's our job to show them how they're going wrong in their thinking, okay, to produce that. And we're going to talk about that in a moment. But let's talk about the other 2 as well. Does my thinking help me to achieve my goals? And does my thinking help me to feel the way I want to feel? And as it says in your manual, 3 yes answers means it's a rational thought. You want to hold on to it because it serves you well. It's accurate. It helps you to get what you want out of life. And it helps you to feel the way you want to feel. 1 no answer to any of these questions means it's an irrational thought for you. And now it's time to develop a new rational replacement thought to practice. And at first, the therapist will produce the new rational replacement thought for the client until they get the idea of how to do this, how to produce them, and then they will start on their own. And developing the new rational replacement thought typically involves determining why the old thoughts were irrational and developing an argument against them. Okay? So one of the most common, as a matter of fact, the most common mental mistake that we will see with panic is this one right here, is the confusion of need and want. As a matter of fact, if I were limited to one mental mistake that I could help a person to correct, this would be the one by far that I would pick. We've identified over 26 different cognitive distortions or mental mistakes, but this is the one that I would pick by far. The others wouldn't even be close. And I can guarantee you, if it's a learned panic response, you will find a need thought somewhere. They're equating something with a life or death situation. Okay. Now, in RLT, we categorize needs into two types. There are two kinds of needs. There are absolute needs and there are conditional needs. Absolute needs are those needs that involve survival, those things that are required for us to remain alive, such as air, food, water, a certain amount of warmth. Sometimes a person needs a particular medication to remain alive. Everything else on this planet, we teach our clients, is a want, is a desire. The only problem as we know, very often people mislabel wants as being needs. So therefore, how do they feel when they go without them? The same as they would. And by the way, this is on page 24 in your manual, if you have your manual printed out. The same as they would if they were going without air and food and water. You can see it in their actions. You can see it in their reactions that they're equating something with a life or death situation. So you've been working with a guy for a while, and one day you meet with him, and he's panicking. He's shaking. His voice is quivering. And you ask him, gee, what's the matter? What's going on? My wife left me. Now, in that situation, did he act as though he wanted his wife and he sure will be disappointed if she doesn't return? Or is he acting like he's going to drop dead any minute? Obviously, his body doesn't lie. We can see that he's equating this with a life or death situation, as if she were air or food or water. Now, while that might sound very romantic, we're going to help him to understand that no matter how outstanding, fantastic, wonderful, terrific, or unique she is a want, thank God, and not a need, especially thank God if she doesn't return. Now, there are conditional need statements that may or may not be accurate. An example of a conditional need statement is to make a chocolate cake, you need chocolate. Okay, so this is required for that type of statement. So that's probably an accurate conditional need statement, right? For a person to make a chocolate cake, they need chocolate. Okay. So let's say the example that I've often given is I've traveled all through the country for many years conducting trainings, and I would say that I would tell the folks, let's say I'm in Kansas or somewhere, I'd say, for me to be home this evening, I need to travel there. That's probably an accurate conditional need statement. However, if they closed down the roads, they closed down the airports, and there was just no way for me to get home that evening, if I panicked over that, then I would be equating getting home with air, food, and water as if I were going to die if I didn't get home that evening. That we certainly can dispute. Okay, so the question is this a matter of life and death, or is this an inconvenience? Maybe even a huge inconvenience, but still just that, an inconvenience. Okay. Someone mentioned the DSM earlier. The DSM is full of examples of the confusion of need and want. Okay. At the heart of many problems, depression and anxiety and anger, you will find that the more intense it is, you will find a need statement there somewhere. Okay. All right, so I can guarantee you that if it is a learned panic response, you will find a need thought somewhere. It's the same reaction they would have if they were in the woods, they turned around, and a bear were ready to attack them. It's the same reaction. So they're equating something with a life or death situation. The question is, are they indeed in a life or death situation? If they are, then they had better deal with that accordingly. If not, then it's time to work at adjusting our thinking. Okay? All right. And we'll apply the 3 rational questions to that. So, I need my wife. I cannot live without her. Is it based on fact, the first rational question? And then we'll move on. Okay? And then develop a new rational replacement for him to think. Okay. All right. Now, on page 25 in your manual, there's also this very common question that we have from clients, and that is, why do I continue to panic? Or at least at first they will say, have panic attacks, until we help them to remove that way of explaining what's going on. Why do I continue to panic even though I'm on medication? I'm taking, at least years ago you would hear this, I'm taking the Xanax that the doctor is giving me, I'm taking the Ativan the doctor is giving me, or I'm taking the Celexa or the Prozac that the doctor's giving me, and I'm still panicking. Why? Well, how I typically explain this is I'll have them look out the window to the street and ask them, if you were standing in the middle of the road as we speak, I don't mean as we speak, I'm sorry. If you were standing in the middle of the road and a car were headed toward you, getting ready to run you over so that you would just be flattened like a pancake, how much Ativan would you have to take for you to not panic? You would have to be in a coma from it. So all that Ativan or Xanax or medications like that, I explain to them, do is make it more difficult for you to panic. But unless you are completely anesthetized, you're unconscious, if you perceive a threat enough, a significant threat enough, you are going to panic. Maybe you won't panic quite as intensely, but you will still panic if you are equating something with a life or death situation. So unless you're unconscious from it, you will still panic if you're equating something with a life or death situation. That is if it's a learned problem. Now, if it's a not learned problem, for example, this panic-like symptoms are the result of an adrenal tumor, then there's a reason why the Xanax isn't helping you. Okay. All right. Any question about that? Oh, okay. We had a question here. Do you train them that it takes time to get the adrenaline out of their system? Well, at the very least, it's going to take time for them to get into the habit of no longer pain. But there's no doubt, if you panic in reaction to something and then you start to calm yourself down, it will take a while for you to calm down because your body was so hyped up from the adrenaline. There's no doubt about that, sure. But you will, if you determine that you are not in the danger that you thought you were, you will immediately begin to calm down. Okay. All right. Okay. Now, the next issue, which is extremely important in helping people to stop panicking, is symptom stress. But unfortunately, it's another issue that is rarely addressed in therapy. Even within cognitive behavioral therapy, many do not know, do not understand symptom stress. Okay, we had one question. Can you self-calm after you're in full panic? You can. I had it today when I couldn't get in. Yeah, right. You can, but it's the best way is to determine if you are indeed as in danger that is commensurate with your reaction. That's the best way to immediately begin calming down. But often what happens, and this leads us to this, and this is how you can almost immediately start calming down, and that is symptom stress. It's a term that was coined by Albert Ellis that refers to being upset about being upset. Some call this secondary disturbance. Okay? Now, symptom stress takes many different forms. It can be being depressed about being depressed, anxious about being anxious, angry about being angry. Sometimes people are depressed about feeling angry, angry about feeling depressed, or anxious about either one. But the bottom line is that the person views emotional distress as being something that is unbearable, intolerable, and very often what we will hear from them is, I can't stand feeling whatever it is they're feeling. And for our discussion today, I can't stand feeling anxious. Now, how do we know for a fact that when a person says that they cannot stand feeling anxious, that is an inaccurate statement? We know it for a fact because they are around to complain about it, to experience it. If in fact they couldn't stand feeling anxious, it would kill them. So therefore, because anxiety itself does not directly kill someone, we help them to change this from I can't stand feeling anxious to I do not like feeling anxious, because it is unpleasant, it is uncomfortable, highly annoying and inconvenient. And that's why I'm working to learn how to stop feeling anxious, how to stop panicking. But until then, I will remind myself that I can stand it, I can take it, and the best proof of it is that I'm around to complain about it. One of the main reasons people panic is because they're scared to death of panicking. Okay, so they will begin panicking about something. Or it could have been simply a physiological hiccup of some kind, maybe an arrhythmia, a PAC or a PVC. And then they will panic in reaction to that. And then they develop this cycle where they're scared to death that they will feel that way again. So then they begin panicking over the possibility that they'll panic. And that is symptom stress. We see this time and time and time again. As a matter of fact, where are many people when they discover that they are panicking? That or they're told you have a problem with panic. They're in the emergency room. Why? Because they thought they were having a heart attack, because the feelings can be very similar, the heaviness in the chest and all. And so they wisely go to the emergency room, they're evaluated, and a couple hours later, the doctor says, I have good news for you, your heart is fine. This was likely a panic attack. But why? But what happened? They panicked. They labeled it a heart attack. And because they're scared to death of dying, what do? They panic even more. And around we go. The more they panic, the greater the symptoms, and the more it appears to them that they're having a heart attack, and the more they panic. So once we have the medical data to show that, in fact, their heart is fine, we're going to help them to develop a thought for them to practice. And that is, my heart is fine. If I feel this way, it is only panic. I'm only feeling anxious. I am safe. Now, the question is, does a Holter monitor make it worse? It can. I mean, now if the doctor recommends having one to make sure that the heart is fine, I would definitely recommend that. But the constant thought about the heart, because you're aware that you're wearing this monitor, surely can make matters worse in terms of anxiety. Them making themselves anxious over the possibility that there's something wrong with their heart. Okay. So therefore, we're going to help them to break this cycle if we have the medical data to prove that their heart is fine. This is only panic, and panic will not kill me. It feels uncomfortable. It's unpleasant. It's very annoying. I very much dislike feeling this way. But that's all it is uncomfortable, not something that will kill me. So what we're doing, folks, is we're moving panic out of the category of life-threatening and putting it into the category of unpleasant and uncomfortable, where it belongs. And I'm telling you, that is a major, major component of panic, the habit people get into of panicking. That's why they will leave their home and panic, because they realized that they forgot their bottle of Xanax at home that they normally carry around in their pocket. Okay. And by the way, this is another reason why people often drink themselves, silly or drug themselves, because they think they can't stand panicking, and they will do anything they can to avoid it. Okay. So taking it out of the category of life-threatening, putting it into the category of unpleasant and uncomfortable, where it belongs. Okay. Now, sometimes we are asked the question, why do I wake up panicking? I'll bet you've heard that before. Why do I wake up panicking? Well, there are some medical conditions that can cause that. So if they say that they are waking up panicking, that as soon as they open their eyes, they're panicking, or they wake up as they're panicking, it's a good idea to have them checked out medically, no doubt about that. What we also want to determine is, could they have been dreaming about something that they fear that caused them to panic? Because the human brain does not know the difference between an image that's produced from external stimuli and an image that's produced internally. That's why dreams seem so real to us. If the human brain knew the difference, it wouldn't react the way we do physiologically to those dreams. Okay, so fearful dreams certainly can be a factor. What most likely is the problem, and we see very often, is they wake up panicking because of their intense fear of panicking. Most people who are in the habit of panicking love to sleep. And why do they love to sleep? Because they figure as long as they are asleep, they will not panic. So therefore, when they open their eyes and they see the ceiling, what are they aware of? That they're awake, which means what is a possibility for them? That they might panic. And that's all they need to know, to instantly panic because of their intense fear of panicking. We see this time and time and time again. So the more that we help them with this symptom stress, to become unafraid of panicking, to take it out of the category of life-threatening, put it into the category of unpleasant and uncomfortable, the less we will see of this, the less likely it is that they will wake up panicking. Okay, if we're right with that hypothesis, we will see that. But if there's some medical condition going on that's causing it, then that needs to be taken care of, obviously. Okay. Any question about symptom stress? It's so very important. Okay. And by the way, sometimes therapists have difficulty with symptom stress, helping people to correct it because they are caught up in it themselves. They view panicking, feeling anxious, or feeling very depressed as they equate it with a life or death situation. And so it's very important for us to work on ourselves to make certain that we have these emotional experiences in the right category. Otherwise, we're going to have a very difficult time helping them to correct it. Right? It's the fear of the fear. It's the fear of the response of your fear, right? That my experience will be so bad that I won't be able to take it. That I will die. And you can see it in the reaction that they're equating panicking with something that would kill them. Okay, I have a young girl with diabetes, type 1 diabetes. She panics on occasion, but is severe. She says her Dexcom is consistent. Should I refer her again to her? Absolutely. Yeah, there's no doubt that changes in blood sugar level fluctuations in that, as well as hormonal fluctuations can cause that as well. But in that case, we will usually see no pattern whatsoever. Okay. Would Gestalt be recommended? Fear the fear or let it come? The concern that I have with that is that what we teach our folks is that every time we upset ourselves, we are practicing being upset. So that is one way. We could engage in a flooding technique of sorts, or intentionally encouraging them to panic to prove to them that it will not kill them. But usually they have the. By the way, we're on page 27 in the manual. You said you think you might not have the right one. See if what we're looking at is on page 27. Okay. But usually they will have enough experience with panicking to know that it doesn't kill them, and they're around to tell us about it. So it's an obvious fact that it hasn't. So it's more a matter of helping them to practice the idea. We're going to develop this new rational replacement thought and then have them practice it, that indeed it's only uncomfortable. It is not something that will kill me. Okay. Now that leads us to the next issue, and that is so-called agoraphobia. Now, nowadays, as I said, many of us are concerned about leaving our home, not because we're afraid we're going to panic, but because we're afraid we're going to contract this virus and then give it to our loved ones, and we'll all get sick. But ordinarily, agoraphobia is the result of a fear of panicking away from home. So first, a person will start panicking, and then they will be reluctant to leave home for fear that they will panic when they're away from home. Also, consider the fact that sometimes people are afraid of panicking at home alone. So not only will they be very reluctant to leave their home without someone accompanying them, just in case they happen to panic, they will also often be afraid to be home by themselves alone in case they panic, and they'll want someone to be there with them. And typically the two most common concerns that people have with panicking, being away from home, is the fear of incapacity and the fear of embarrassment. Okay, so let's look at the fear of incapacity. It's on page 28 in the manual. So the idea is this: I will pass out. If I panic, I'll pass out, and no one will be there to help me. Now, let's just take a look at that one first of all. If I panic, I will pass out. So there are two parts to this. One is that I will pass out, and the second is that no one will help me if I pass out. First of all, it is very, very unlikely that a person will pass out from panicking. Very unlikely, unless they have a blood sugar problem or cardiac problem. It is very, very unlikely that they will panic. That they will pass out from panicking. What happens to a person's blood pressure when they pass out? It drops. What happens to your blood pressure when you're panicking? It increases. So your blood pressure is actually going in the opposite direction required to pass out. But the reason it seems to people that they will pass out is because they get lightheaded, they get dizzy. That's from the increase, mostly from the increase of blood pressure. So no matter what Tony Soprano did on The Sopranos, I giggled every time I watched it. It's very unlikely that a person will pass out from panicking unless they have a physiological problem, an underlying problem. And if they tell you that they're passing out from panicking, then we need to get them evaluated. But then the second problem is that if I pass out in the middle of Walmart under usual circumstances, if I pass out in the middle of Walmart, no one will help me. How likely is it that no one will call 911, or provide some assistance in some way? Now, granted, we know from social psychology research that the more people that are there, the less likely it is that someone will help you. But at the very least, a store manager or someone will jump in and help out. But the question is, will I need help to begin with? And in terms of passing out, the answer is extremely unlikely. Or what we'll hear, I'll bet you've heard, I'll pass out while I'm driving, and I'll be so affected by the anxiety that I'll wreck. Well, the same applies to driving in terms of passing out. But could a person be too anxious to drive safely? Well, I suppose so if a person is distracted. But in my experience, I've found that people, I remember one guy, our headquarters is about 35 miles from downtown Pittsburgh. And he told me that he started panicking, and he lives in our town. He started panicking in downtown Pittsburgh and drove from there all through the streets of downtown Pittsburgh on the parkway, heavily congested at rush hour, all through there while in the midst, full-blown panic, and drove all the way home and didn't wreck. So I said to him, now, would you have been much more comfortable and confident in your driving had you not been panicking? He said, absolutely. But what does the fact that you got home prove? He said, well, I guess that I can drive home even if I am panicking. Now, how did he happen to panic to begin with? Because he was in downtown Pittsburgh, and his thought was, my Lord, what will I do if I panic on my way home? And that's all he needed to think. That's the only question he needed to ask himself. The problem was he didn't give himself a rational answer. The question was reasonable. It was the answer that, oh my God, I'm going to wreck and I'm going to die, and what's going to happen? That's the problem. The other problem with agoraphobia, as generally speaking with panic, is that there is nothing that I can do to prevent it, because there's that it monster once again. It just comes out of nowhere. It just happens. I have a panic attack. Well, what they're understanding, as soon as we start teaching them the emotional ABCs and we start to identify thoughts that are causing their panic, is that there is no it. There's not this thing that dwells within them that makes them panic. It's their fearful thoughts, thank God. So therefore, not only is there not an it causing you to panic, you certainly can stop it and prevent it by learning how to refuse to think those thoughts that caused you to feel anxious and to panic to begin with. Okay. Now, notice something else on the screen there, the safe zone myth. I remember I was performing therapy over the phone with someone a few years ago who lived in a large city, and he wanted help for his tendency to panic himself, and he was agoraphobic, but he did say, I do have a safe zone that is about 5 miles away from home. And he said, and I know that if I remain within 5 miles away from home, that's safe, because if I happen to panic, I can get home safely. The problem was, and after I taught him the emotional ABCs and the rational questions, was that the problem is that he assumed that 5.5 miles away from home was unsafe. You see, the problem with him calling 5 miles, the 5-mile radius, safe, is that the implication was that anything beyond that was unsafe. You see, and so therefore, I helped him to relabel this. This isn't your safe zone. This is your comfort zone. This is where you're comfortable driving to. You're comfortable with the idea that if I remain within this radius of my home, I will make it back. But it is no less safe. I mean, it is no more safe than 5.5 or 10 miles away. Okay. So helping them to understand that because often that this was a very common this is a very common thing that we will hear. I have this safe distance. Well, no, it's your comfortable distance. It's not that anything beyond that is unsafe. Okay, and also having an out is very important, especially at first. So a person tells you, "Well, I mustered up the courage to get to your office, which is 5 miles from my home today, but I'm not so sure I'm going to be able to do that the next time." You know, when they first begin therapy. So therefore, we will help them to have an out. Okay, along the way, are there any places where you can pull over in case you happen to feel dizzy, you happen to panic, and you want to just collect your thoughts and calm down, slow down your breathing? Are there places along the way? Oh, yeah, sure, there's this place here. So we're going to chart that out and have a plan of action. If I happen to panic, then this is what I will do. I will pull over here, or I will pull over there, and I will be safe. And the same on the way home, okay, until we can help them to stop panicking altogether. But as I mentioned, if they have a very difficult time, getting to the office or getting to the location where you perform therapy, then the rational hypnotherapy technique might be something that you would want to study and to utilize. Okay. We have a question. Anyone else wasn't able to log on until after 30 minutes? Yeah, apparently several folks were, and we have no idea why on our end. That's something the Webinar Ninja folks are going to have to answer for us. But there is a replay of this. You'll receive an email, and if you do not see it, about 5 minutes, I believe, after the, I think it's about 5 minutes. It could be longer. About 5 minutes after, you'll receive a link for the replay. Thank you. I appreciate it. And you'll be able to watch it. And then if you're interested in the CEs, you'll receive that information as well. Okay. So sorry about that, folks. We've had used this platform for supervision, and it was fine. So we had no idea that this was going to do this today for you. All right. Let's see. Someone asked, do you think hypnosis can be Christian based? It can be. It can be. She's asking this. She knows my orientation as a Christian. As a matter of fact, I'm pastor of a church. It can be. There are some approaches to hypnotherapy that I'm not so sure about. but the way that we approach it in very straightforward, direct suggestions very much can be. Okay, the second part of this aspect of agoraphobia is embarrassment. So for some, there's certainly the concern of incapacity, whether it's away or at home. What if I pass out at home and there's no one there to help me? But the second is embarrassment. I'll pass out and look like a fool right in the middle of Walmart. I'll pass out and look like a fool, and people will see me shaking and think that I'm an idiot. I'll be the laughing stock of the community. And what is this all based on? The idea I have to concern myself with what they think, with what other people think. As a matter of fact, I've been working on a book, and one of these days I'm going to finish it, hopefully this year. The title of this book is, If Everyone Likes You, You Do Not Know Very Many People. You cannot know very many people if everyone likes you. Okay? And so really it's getting at the heart of the concern that people have, their tendency to be overly concerned with people's thoughts about them and their reactions to them and their disliking them and all that. I'll pass out and look like a fool. Well, we utilize the camera check of perceptions for that idea. And that is this. Okay, so what technique to try to get overcome shame? Sure. And that is this. First of all, the camera check of perceptions technique is an outstanding technique to help people to say what they mean and mean what they say. It also helps us to utilize language accurately. What are we saying? Our thoughts cause our feelings and behaviors, right? Well, what are our thoughts made up of? Words. And each word in a sentence helps to provide meaning for that sentence. So you could have a one-word difference between two sentences and have a completely different reaction. So if I said to my wife, on the way home from work, I'm going to stop at the store, that'll likely be met with a much different reaction than if I said, on the way home from work, I'm going to stop at the bar. It would make the difference between whether or not I end up with a knot on my head. Okay, so with a camera check of perceptions, we would utilize that. So remember, the first rational question is it based on fact that is my thinking based on fact? So is it based on fact that if you passed out, you would look like a fool? If we were to take a picture of you passed out on there on the floor and showed around town and asked people, what do you see in this picture? Would they say, oh, that's a lovely picture of a fool? Of course not. They would say, who is that person? Who is that person lying down on the ground? They might even say, why are they lying down on the ground? Why would they not see a fool? Because there's no such objectively identifiable thing as a fool. So that if everyone looked at it and say, you see, that is a fool. Okay? So therefore, you cannot be something that doesn't exist in reality. Now, if you think they would think, so what do you really mean when you're saying I would look like a fool? They might say, well, I would look like someone who was sick or someone who was incapacitated in some way. Well, isn't everyone capable of getting sick? Isn't everyone capable of being incapacitated in some way? People just take their turns getting sick, don't they? And so therefore, if you dropped with a heart attack and needed CPR and the ambulance to come, people are going to look at you and think, well, what kind of an idiot would fall? And if they do, why are you concerning yourself with the opinions of someone who would fault you for being sick? Okay, that's number one. Secondly, how likely is it? So what happens? You pass out on the floor at Walmart. These people go home and they tell their family, boy, you wouldn't believe what I saw today. Someone passing out on the floor at Walmart, which, by the way, we already talked about, is very unlikely when it comes to panic. But let's say they just happen to because they have some other underlying medical problem that caused that. They'll go home and tell their family what they saw. Their family might tell other people, But then after a while, what is likely to happen? The next morning, are they still going to be talking about this person that collapsed in Walmart? If they do, they need to get a life. They must be really bored if that's still on their mind, unless it was someone they knew and they were thinking about them and wanted to check up on them. Otherwise, why on earth are they still thinking about this? People will see me shaking and think that I'm an idiot. Well, I suppose that's a possibility that they would think that you're something that doesn't exist in reality, an idiot. However, there are many other possible things they might be thinking, like, gee, what's wrong with that poor person? Or I wonder why they're shaking the way they are. But then ultimately, and then this laughing stuck to me, but ultimately the question is this, is how much do I need to concern myself with their opinion? Number one, I will have no idea what they're actually thinking unless they tell me. And even then, I'm just assuming that they're telling me what they're actually thinking. But secondly, if they do not in any way share what they're thinking with me, and they do not mistreat me in any way, then who cares what they're thinking? It makes absolutely no difference whatsoever. And this is the approach that we take, is that people's thoughts are just that. Their thoughts, it's mental activity, something that goes on between their ears. God only knows what people think of us. Who cares? It's their actions that might matter. It's their actions that might create a problem for us in relation to our goals. So therefore, if you pass out in the middle of Walmart and then come to and no one mistreats you, no one shuns you, you're not kicked out of the community, who cares what they thought? It makes absolutely no difference whatsoever. Because one of the things that we teach in rational living therapy is that you cannot have a problem without having a goal. That's what makes something a practical problem, is that it's interfering with a goal of yours. So therefore, if their reaction, whatever it might be, interferes not at all with what matters to you, then what difference does it make? Okay. All right, let's see. If a client was to see a person view a picture of them passed out, likely they would be shocked. Would this also cause embarrassment? No, well, only if they concern themselves with what they might think about a person being passed out. See? Because their viewing you passed out doesn't cause embarrassment. It's your thought that it's a shameful thing to be passed out, and that you need to concern yourself with what they're thinking. That's what would cause embarrassment. So therefore, right, yeah, the client's perception, that's exactly it. So the question is, now that I've passed out and I've come to, do I actually have a problem? Does the fact that I passed out create a problem in front of them, right? Because you're not embarrassed by yourself. If I pass out in a social situation, does that in and of itself create a problem for me? Does their reaction create a problem for me? Or is it only between my ears? Okay. Is it only what I'm thinking? Oh God, what if they're thinking this? What if they're thinking that? But the point is it matters not one iota what they're thinking. How they treat you is what matters. Their thinking is only their mental activity. Their mental activity is not going to affect you at all. It's their treatment of you. So if they continue to treat you well, do not shun you or any of that, then you don't have a problem. Okay. And as a matter of fact, if people insist on being embarrassed, then that's when we might make use of a technique that Ellis liked to use, and that was shame attacking exercises, where a person intentionally does things to attract negative attention from people, to prove to themselves that they can take it. You know, Ellis used to encourage people to tie a string to a banana and to drag it through a store, for example, or to, on an elevator, yell out the floor, second floor, that kind of thing, or a train that stops, which in New York City, I'm not sure how you actually draw negative attention to yourself, but So there are exercises we can do if a person insists that that they need to be concerned with the opinions, negative reactions from people. But most people will get it. They will understand, as long as people do not mistreat me, it makes not one bit of difference what they're thinking. But now this all supposes that they will do something to create negative attention because they're panicking. Okay. And by the way, if they live in a community where they think that somehow panicking would be viewed as a negative thing, they can just simply say, "I don't feel well, right? I'm lightheaded. Maybe my blood sugar is low or something." They don't have to broadcast that they're panicking, but not that there's any objective shame to it. But if they're concerned, they don't have to broadcast that any more than they have to broadcast anything else. Okay, does that make sense? Okay, so we're helping them to refuse to create a problem where one doesn't exist. So it's the fear of incapacity. Will I indeed have a situation where I'm not able to function because I'm just too anxious? Do you talk about clients viewing the world as judgmental and critical? Oh yeah, there's no doubt about it. And that's part of of what I'm writing about in the book. If everyone likes you, you don't know very many people. Yeah, there's no doubt about it. First of all, there is no point in assuming people will be judgmental and critical when going into a given situation. So you're about to give a speech. You're about to give a speech, or you're about to have a performance, or for some people, just to walk across a room and concerned how people will react to their walking. To refuse to assume that people are going to view you negatively or judge you critically because of what you've done. But is there the possibility of that? There is no doubt. There are some people who believe that their purpose in this world is to be judgmental. They look for reasons to be critical. And so therefore, the question is, how much do I have to concern myself with their judgment, with their critical opinion? How much do I need to? Now, if I'm applying for a job, if I'm being interviewed for a job, and the interviewers are critical of what I'm saying, negatively critical, then I have a problem in relation to my goal of obtaining that job. But unfortunately, people do not limit it to that, those types of situations. They think they have to have everyone like them. They think they have to have the positive opinion of everyone. And the question is, for what? Just for what? For what purpose? You cannot have a problem without having a goal. So therefore, if someone is being critical of me, then I have to ask myself, number one, is this an issue that I need to concern myself with? That they would dislike what I have to say? Okay. And now if it is because it's an issue that relates to a goal of mine, as long as they are critical of me in this way, it's going to be difficult for me to achieve this goal, then I might want to address it. Otherwise, who cares? What difference does it make if they are critical or not? Okay. All right. Let's see. Shame is usually super deep rooted. They used to deflect by judging others. Oh, well, it certainly can be a projection. People, and for one thing, and that's often the reason why people are so afraid of the reaction of others, because they know what they do to others. They know how critical they are of others. And so therefore, they assume everyone else does the same thing. There's no doubt the projection that often takes place. Not to mention the fact, look at the arrogance. I know this is kind of a different topic, but I often talk about avoidant behavior, where people are scared to death of others and their opinions of others, and so they shy away from them. It is really based on a somewhat arrogant attitude. And that is, as I'm walking through the cafeteria, scared to death of what people are thinking of me as I'm walking through the cafeteria, people have nothing better to do than to watch me. Watch me with every step that I take and to examine what I'm wearing. See, that's kind of an arrogant attitude, isn't it? So they're not intending to be arrogant, but it's a pretty arrogant attitude that people have nothing better to do than to evaluate me, to inspect me. Okay, right? So okay, so we have another question. So you explore whether their goal is realistic or unrealistic. Well, whether it's rational for them or not in relation to their abilities, certainly. Well, there's not a way to pause the presentation as far as I know, but you can certainly watch it again. There will be the replay of it. Okay. All right. Okay, so let's move on. So agoraphobia. Now, then we teach the next step in the therapy is typically, so we're in this phase where we are examining thoughts with irrational questions, helping them to dispute those thoughts with irrational questions, developing new rational replacement thoughts. And this is outlined in your manual. And if yesterday you were supposed to have received an email with the link to the manual. If you did not receive that, check your junk folder or your spam folder. It's likely in there. If you didn't receive it, be sure to email me and I'll send you the link to it. Okay. And so it outlines the process of the therapy. This is the next stage, the stages of emotional reeducation. And then we get to the stage of the terminating formal therapy. And we have these 4 questions here. Has the client achieved his or her goals for therapy? Has the client learned everything necessary to obtain long-term results? Our goal is for the client to never need therapy again. Okay. And so have they learned that? Have they learned about the ABCs of emotions, the rational questions, the rational action planner? It's all in your manual. Has a client corrected his or her underlying assumptions? Very important, because if we do not correct those underlying assumptions that we talked about, that we identify with the downward arrow technique, we're likely to see them again, or at least someone will. And they will likely continue to panic. Okay. And does the client know why he or she is doing well? 4 questions that we ask. Very important. If the client says, yeah, I'm doing well, but I have no idea, then how much confidence can they have that they will continue to do well? On the other hand, if they say, well, I know exactly why I'm doing well, because I eliminated that panic-producing thought and replaced it with this one, and I'm doing these things instead of those old irrational things, then we know that they know what they're doing, but far more importantly, they know that they know what they're doing. Okay, let's see. We have a couple questions here. I've lived in a TC and had 0 skills other than perfection of manipulation. What is the time frame to ask these questions? I'm thinking 6 months with no medication there. Okay, well, this is when we ask these questions is when it looks as though we have addressed all of their thoughts and underlying assumptions that they've presented to us that are causing them to feel in ways that they do not want to feel or that are contrary to their goals. Now, this webinar was specific to panic and agoraphobia, but if they also have other things going on that they're presenting in the course of therapy, once it looked like, because remember, we're going to have them break down their reactions to the ABCs, and we're going to have them continue doing that throughout the process. So therefore, each week they're going to bring in new ABCs that they've written out for us, and we'll have new thoughts to help them examine with the rational questions. But the entire therapy is geared toward them being able to do this on their own. And so once it looks like indeed we've addressed all of their thoughts and underlying assumptions, and they've learned all that they need to know in the process for them to never need us again, that's when we will ask these 4 questions. And the average number of sessions is about 16, okay, 16 sessions. All right, any other questions? Okay, let's see. Is there some facet of self-image repair in CBT? Oh, yeah, certainly. And right, and one of the things we do is separate person from behavior. There's no doubt about that. So there is because often what people do is they will equate their self-image with who they are. And what I tell folks is the best way to determine who you are is to get out your wallet and look at your driver's license. That will tell you who you are. So we're separating person from behavior. Who I am is Aldo Pucci. What I do is not me. It's me doing those things. I'm doing those things. But if I do things completely different a year from now, am I no longer Aldo Pucci? Of course not. So we're separating person from behavior, and help, because otherwise they're going to think that they are forever attached to what they have done. For example. Okay. All right. Any other questions as we head toward the end of the webinar today? So what is panic? Panic that is actual panic and not the result of hypothyroidism or a pituitary tumor or an adrenal problem, is fear, is a result of fear, intense fear, equating something with a life or death situation. And at the heart of that is the confusion of need and want. Now, if you're standing in the middle of the woods and a bear is ready to attack you, then you probably are in a life or death situation. And it's a good thing that you recognize it as such. But if you have the same reaction standing in front of a group of people about to give a speech, then of course you're not in a life or death situation unless they have promised to shoot you if they dislike what you say. Okay. Otherwise you're not. And so therefore it's problematic to equate that type of situation, have the same reaction as you would if you were in the woods and a bear were ready to attack you. So at the heart of that is that confusion of need and want. And the more that our clients understand the difference between absolute needs and wants, the better off they'll be. And the less likely it is that they will panic. But we need to develop the new rational replacement thought. I only want my wife in that example that we gave. I in no way need her like my life depends on her. So therefore, when I think about the possibility that she will leave me, I will remind myself that I can live without her. I'd rather not. I hope she doesn't leave, but I can live without her. I just would rather not to. And so if she does leave, I'll be okay. I won't like it, but it certainly will not be the end of me. Okay, and so attacking those need ideas, and also the symptom stress, so very important. Once we help people to move panic and intense anxiety out of the category of life-threatening and put it into the category of unpleasant and uncomfortable, you will see a dramatic decrease in their panicking because you have helped them to remove the component of their panicking over the possibility that they'll panic. Okay, and it's so very helpful. It's such a sad thing that rarely does that get addressed. How much panic is based on lack of self-confidence? Let's see. And perhaps lack of experience. Well, that's just it. But if you think your lack of self-confidence is going to result in a life-threatening situation, then that becomes a problem. Okay. All right. Looks like we have about 20 seconds left. And so, so therefore, you're going to get an email, and it's going to give you a link for the replay. And as a matter of fact, I'm going to send everyone. I have your email. I'm going to send everyone a link to that, and so you can watch it and then go to the CE area to get them.